So, Mr. Chairman, ladies and gentlemen, I'd like to thank the organising committee and Ethicon for the invitation here today to speak about the bicuspid aortic valve. And it's an area of some controversy, and it's an area perhaps which is poorly understood. And the things which I want to run through today are, firstly, the classifications, because there's a classification now. The natural history, which is, I think, it's sometimes confusing, and the more I read about it, the more confused I became about it. Aortic dilatation, and some of the reasons which are now being looked at why that occurs. And finally, the question which everyone asks is, what the hell do we do with the ascending aorta? So a number of different people have tried to classify the bicuspid valve, Rousseau, Angelini, and they've based it on the number of raphe, the position of the cusps, the anatomy of the cusps. But I think perhaps the most useful classification is this, the Sievers classification. And you may remember this, Mr. Graham, that one of your registrars started putting this on your operation notes. So this is what it is. That's what they were putting on there, okay? Unfortunately, it wasn't me. It was the clever one who did it. So the Sievers classification, they looked at bicuspid aortic valves taken out of 304 patients, and they came up with a classification. And they based it upon one major category, and that's the type. And that type is dictated by the number of raphe that they find. Then the spatial position of the cusps, or the raphe, and finally the function. So it gives you a three-letter classification, rather analogous to pacemakers. So there are three major types. Type 0, no raphe. You can see here. So type 0, no raphe. This is the truly bicuspid valve. Type 1, where you have a valve which can potentially be tricuspid with a single raphe. Type 2 with two raphes there. So these are the classifications. And so types 1 and type 2 are potentially tricuspid valves. Type 0 is the true bicuspid valve. And their relative frequencies throughout that study. Well, the type 0 is relatively uncommon, about 7%. The most common is type 1, 88%, and the most common variation of that is the raphe between the right and the left coronaries at about 80%. And then about 5% of this of the type 2. And then the last, so you can classify as type 1, LR to denote where the raphe lies, and then S for stenosis, I for insufficiency. So looking at the operative pictures, this is a type 0 with no raphe, so a bicommissural, truly bicuspid valve. This is the valve excised here, and there is no raphe that can be seen. Type 1, here we see a tricommissural, something which is trying to be a tricuspid valve. And here we see the raphe here between the right and the left coronary cusps, and then dependent, so type 1 LR, and then dependent on the pathology. And type 2 here with the two raphes. So the natural history, well, some facts about it. It is the most common cardiovascular abnormality, 1 to 2% of the population, male greater than female preponderance, and there are associated conditions with it, Turner syndrome, coarctation of the aorta. And the problems with associated proximal aortic disease are not fully understood. There are believed to be genetic components to it. There are believed to be flow-related components to it as well, but it's not fully understood. And perhaps one of the most confusing topics, or one of the most topics which I find confusing about this, is the association with dissection. And it depends on what you read, how they've gathered their cohorts as to what the association with dissection is. And it varies from less than 1% in cohorts to 10% of patients with dissection have a bicuspid valve. But it's a common thing. So if we look at all the patients who have aortic valve surgery, then 30% of those will have a bicuspid valve. And a large proportion of patients with a bicuspid valve will develop aortic stenosis or aortic regurgitation over their lifetime, and so they should undergo serial echocardiographic follow-up. And when you diagnose a bicuspid aortic valve, you should try and visualize the aortic root in the ascending aorta. And it may be that that's perfectly acceptable to be visualized by transthoracic echocardiography, but you may need CT or MRI. Certainly, if the diameter is greater than 45 millimeters on transthoracic echo, then additional cross-sectional imaging is advised and annual follow-up is advised. And in the aortic service in Birmingham, we will be sending quite a large number of people with relatively small ascending aortas, somewhere in the region of 45 to 50 millimeters, and all of them will undergo echocardiography if they haven't already, and we will base their follow-up dependent on whether they have a bicuspid valve or a tricuspid valve, as well as age and other patient-related factors. Screening, so screening of siblings, there is a strong familial association, and somewhere in 10 to 30% will have a relative with either a bicuspid valve or an aortopathy. The patterns of inheritance are variable and not, as I say, not fully understood. And screening is particularly recommended if there is within that family history, so it's beholden on if you have a patient with a bicuspid aortic valve, you should take an accurate family history, and you should look for rupture, dissection, or history of sudden death and early age within that family, because there may well be a familial component which needs proper follow-up. So, Olmsted County, Minnesota, has provided us with an instance of aortic complications in patients with bicuspid valves. So they followed up 416 patients with a definite diagnosis of bicuspid aortic valve, and they found that the risk of dissection was fairly low. So only 2 out of 416 of those patients went on to have a dissection. That was slightly higher than within the general population, but still low. But at 25 years, about 25% of patients would have had some procedure on the aorta. The risk of dissection is low, but within this group, if you look at the years after diagnosis, there's no difference between their observed and expected survival. Dissection risk, as I said, it does vary depending on what piece of literature you read. It's like the risk of rupture or dissection increased once the aorta gets above 50 millimeters. Svensson looked at a cohort from the Cleveland Clinic with 430 patients with bicuspid valve who had undergone surgery. 40 of those were dissections, 25 of those were acute, and 5 of those were less than 50 millimeters. That's 12.5% of that population. And that compares with sort of about 15% of Marfan's patients will dissect with aortic diameters of less than 50 millimeters. Autopsy studies show that 9 to 15% of patients with dissection have a bicuspid aortic valve. And the IRAD data and ETSIS data from Leipzig shows that in dissections less than 40 years, the patients are more likely to have bicuspid valves, with 9% of those less than 40 having a bicuspid valve compared with 1% in the older age groups. So aortic dilatation, is it the same for all the different categories of bicuspid valve? No, it isn't. So for ascending aneurysms, it's the type 2 valves which have the highest incidence of ascending aortic aneurysm. So 60% of those will have an associated ascending aneurysm. 25% of the other group. And root dilatation tends to occur in the type 1 LR, the most common morphology of bicuspid valve. And so there are two thoughts as to why you get proximal aortic disease. Well, the first is it's a genetic problem. It may be embryological. There's an association with proximal pulmonary artery dilatation. So a number of the children's centres have advocated previously Ross procedures for these, but I think they've become slightly more guarded now in these patients with proximal PA dilatation, because this may not sort out their problem. You see accelerated medial degeneration, as you do in patients with Marfan's, aortic collagen contents, elastin fragmentation, vascular smooth muscle, apoptosis, increased MMP2 activity, and there's an association with the familial thoracic aortic aneurysm. And this is all poorly understood. But the GENTAC group, which is headed by Diana Milovitz, which has come out of IRAD, has set up a bicuspid aortic valve consortium group, and they are looking at the genetics of the bicuspid aortic valve. So flow. And I make no apologies in having stolen this from the Aortic Surgery Symposium in 2014. And I thought this was a lovely presentation when I saw it. So this is about a few minutes. I just wanted to show you some Christian Etz's data on flow-related aortopathy.
Was to come up with an experimental setting and go to the lab. When discussing this endeavor with one of our brightest young medical students, she asked me one day, could you not just suture two leaflets together and mimic a bicuspid valve? And then the idea of excluding genetic influences for BAV patients was born. So we went to the lab, bicuspidalized a native tricuspid aortic valve, mimicking the most common Sieverts types 1 with a left and right cusp fusion and a right and non-cusp fusion in angular settler pigs. So about 12 weeks old, 30 kilogram. That was about the weight of those little animals. And then we went to the MRI scanner and did 4D MRI flow analysis. And for the first time, we were revealing flow in the proximal aorta, even with low transvalvular gradients after bicuspidalization procedure, successfully isolating the effect. This is the surgical setting, very simple. Lateral thoracotomy via the fourth intercostal space, cardiopulmonary bypass. And then we did this valve changing procedure, closed the aortotomy, weaned the animal from bypass. And this is what we got from our flow analysis. You see here, this is 4D MRI flow analysis prior to experimental bicuspidalization. You see laminar flow through the normal valve. With the software that we used, we can not only analyze slices, but we can calculate peak velocities in certain areas, and we can, of course, then draw conclusions on wall stress. And this is the MRI after bicuspidalization. Here an example of a left and right fusion, and you see this really impressive vortex formation that we get. And this is the very same animal, and if we do the analysis, then we see that we get different peak velocity areas here as compared to the previous more homogeneous flow. And it gets more impressive when you look at both of these flow pattern next to each other, though this is the same individual animal with laminar flow through its tricuspid valve and vortex flow after bicuspidalization. So in conclusion, this is the first large animal model to allow for experimental analysis of specific flow pattern in bicuspid valves. It will enable us in the future to do research on specific flow architecture triggered or as opposed to genetic changes in enzyme activity, smooth muscle cell function, and extracellular matrix. Impressive vortex formation in the proximal aorta after bicuspidalization occurred, and there was no significant flow alteration in the descending aorta. That is probably correlating with our clinical experience. And this model will allow for long-term evaluation of the effects of altered flow dynamics on aneurysm formation in growing juvenile animals and excluding the genetic influence. So the ultimate goal is the translation into clinical practice, allowing for individualized flow architecture-based risk stratification. Before I finish, let me share with you one really even more impressive and exciting discovery. On December 12th, about 4 months ago, we scheduled an experiment on a Saturday early in the morning, and when I was operating on this animal, I was talking to my assistant, and I said, you have to pull a little bit more, I can't see the commissure, and this is what we actually were seeing here. This was the first native bicuspid pig that I've personally seen, and I haven't heard about any other experience with this, and you can see here this thinned out non-coronary sinus in this animal. So we're hoping that we can breed these in the future. And of course, we did an MRI, and this is the impressive flow through this native bicuspid valve. You see here in slow motion how this vortex is forming. And then if you compare this with the human setting, here on the left, you see this is a patient that had the same MRI. It was a left-right, so the most common type 1 fusion. And compare this with a bicuspid pig. You have to imagine that this is about the level of the valve. Then you have real impressive similarities. So I think it's a pretty good model. And this is the last movies I want to show you. This is only isolating the vortex formation. And you can really imagine how this is drilling here inside the proximal aortic wall. Thank you very much for your attention.
So I think some quite impressive work about what might happen in the future in terms of trying to elucidate mechanisms of genetic versus flow-related aortopathy. So, the final question, what to do with the ascending aorta? Well, it's based on 4 sets of guidelines, the valvular guidelines and the aortic guidelines from each of the, from the ESC and AHA-ACC. And I'm going to concentrate on the most recently published guidelines from 2014 from both groups. So the 2014 ESC EACS guidelines. So in cases of bicuspid aortic valve, when you're not dealing with the valve, surgery of the ascending aorta indicated with the root or ascending aorta greater than 55 millimeters. With the aortic root or ascending aorta greater than 50 millimeters in the presence of other risk factors, then replacement of the ascending aorta or root is indicated. And so they rather nebulously include systemic hypertension, which I suspect quite a lot of people have, family history of dissection, which I think is very reasonable, or increase in aortic diameter greater than 3 millimeters per year, which is slightly different from the American guidelines and some of the criteria which we've traditionally used. But certainly in groups of patients who have other risk factors such as Turner syndrome, Marfan's, you would stick with the same criteria. And when you're proposing surgical aortic valve, they say greater than 45 millimeters. What do the American guidelines say? Well, they considered they were slightly more aggressive in their previous set of guidelines, and they've slightly changed what they've said this time around. And that's based on 2 large long-term retrospective studies. The first, which we've already seen, which is the Olmsted County data, where the risk of dissection was slightly higher than within the general population, but still low. They also say there is lack of evidence as to the degree of aortic dilatation at which aortic dissection is a risk, and we know that. But it says a Class 1B, Class 1, level of evidence B, if aortic valve replacement is not indicated, surgery is recommended for the aortic sinuses or the ascending aorta dilated at more than 55 millimeters. Class 2A, level of evidence C, when the AVR is not indicated, surgery for the sinuses or the ascending aorta at greater than 50 millimeters in the presence of risk factors, family history, other risk factors, dilatation greater than 5 millimeters per year. And a Class 2A, if an aortic valve replacement is indicated, aortic replacement is reasonable. I think that's the word you want to be looking at, reasonable, if the sinuses or the ascending aorta is greater than 45 millimeters. And sinus replacement surgery should be individualized. But what happens if you do nothing? So this is some data from Michael Borger, where they looked at 325 patients who underwent aortic valve replacement with aortic valve stenosis and had ascending aortic dilatation at around about 40 to 50 millimeters. Survival was slightly greater in the bicuspid group, but that's because they're a slightly younger age group. But freedom from aortic reintervention at 50 years was about 90%. in that bicuspid group and 80-odd% in the tricuspid group. So we've talked a little about classification and natural history, the mechanisms which lead to dilatation, and confuse you about what we should do with the ascending aorta. So in summary, it's common. It's likely to require surgery at some point in life, and there are different types, and those different types have different phenotypes. Aortic dilatation is common, and it's proximal dilatation. Dissection risk is low, but still higher than within the general population. And for a functioning valve, I think it's the same indication for operation as per ascending aortic aneurysms. And at the same time of a valve procedure, there's a lower threshold, but the treatment needs to be individualized. Thank you.
Thank you very much. Questions from the floor? While you're thinking, Andy's got a question.
Can you help me with what is becoming an increasingly common presentation, which is the patient with an ascending aorta sufficiently dilated, it's above the threshold, say 5.7, but the mid-sinus diameter is, say, 3.9. They have a bicuspid aortic valve, which is competent, and it's not stenotic. So there's an indication to do something for the ascending aorta. What do you do with the rest?
I don't know. I think it's difficult. I think you have to individualize it based on the patient. On the patient. So if there's some aortic valve leaflet calcification, you may well want to go and do things. If there's a little bit of regurgitation, you may want to do things because you're going to be going back in there at a later date, almost certainly. But it needs to be individualized. Things which we would particularly look at are things such as position of the coronary oster, so coronary osteal migration would be an indication where we, in that kind of setting, that we would perhaps in young patients recommend root replacement for that patient. And then you get into the thorny element of what you do with the valve in that setting, whether you spare the valve or replace the valve. And I think sparing or replacing really depends on your expertise and your ability to leave a patient with a low risk of reintervention.
Yeah, I'd agree with all that, but it makes consent almost impossible.
Aaron, can I just pick up on, you almost intonated about screening if there was a strong family history of dissection. I have to say it's my practice to suggest screening in all first-degree relatives when there's a sort of 10% chance of one of them being affected. And simply because although you're going to present with your valve disease, you won't necessarily know about your aortopathy until the time comes. So, and also because I can get in nagging about the endocarditis and not getting a tattoo, and they have a warning card so that hopefully they will go with that illness after a week and get the appropriate bloods, and we pick them up early. So I think I would suggest that we screen all. I know there isn't a UK programme, but I think probably we should be thinking.
Yeah, I would say we in Birmingham with the Aortic programme, we are more aggressive because we have a number of congenital cardiologists who are happy to take those patients on and follow them up, and will counsel them very thoroughly and actually take a proper family history, unlike the family history which I take. But so no, and you have a simple, non-invasive investigation which you can do, and so I'd agree with that. I think that screening will be paramount, and we do have a more aggressive screening policy.
Okay.
Question from the floor.
You may have met this situation yourself, but I find quite a few patients who come to me for surgery and they need aortic valve replacement for stenosis, but their range of aortic dilatation is in the range of 45 to say 49, and they're usually of the age group of 74 to 80 plus. Now, they use the word reasonable. I find it difficult to sometimes speak to my patient and say, look, you need an aortic valve replacement, but I think I might also replace your ascending aorta. My preference is to give them a safe operation and let them go home. That's my reasonable thought processes. But I would like to know what other people think here.
I think that's a very reasonable thought process. I think it's fine to consent them for aortic valve replacement and say, I would look at the aorta at the same time. If something needs to be done, I would do something about it. And I think at 45, 49 millimeters in a 70-year-old, you've got the Michael Borger data there, which shows that actually, you know, you've got a good chance of being free from aortic reintervention. I would base it, again, based on what you see at the time as well. So if it's a very, very thin aorta, then you might think of doing something about it. But I would, when I'm faced with that kind of patient, I will counsel them for aortic valve replacement, mention the possibility of an ascending aorta, but I think for that age group, the quickest, simplest operation is the best thing to do.
I agree, and the survival data shows you're doing the right thing at that age group. Andrew?
Do you have a strong view on whether we should be doing interpositions or root replacements? I think a lot of us doing aortic surgery now tend to replace the root because the feeling is that the sinuses are likely to be involved with people with bicuspid valves, and it can be done with relatively low risk. But actually, when you look back at a lot of the data these guidelines are written on, then people are saying you've got to replace the aorta, and vastly, 3/4 of the series will be just an interposition graft rather than a root replacement, which is a very different operation in most people's hands. So do you have a strong feeling of the issue advising people to do full roots or interpositions?
I think we would take a very individualized approach to it. So we will make our decision at the time, and again, a lot of it is based on coronary position, actual anatomy of the root when you look down. So we will base it on what we see at the time. But again, if we suspect from CT scans, preoperatively, again, we will consent people for root replacement.
I think that's a good question. The guidelines don't differentiate. They say the ascending aorta or root.
Yeah.
I think if the coronaries are high and a root replacement is easy, it suggests the sinuses are really enlarged and you can do it. If the coronaries are really low, it suggests the root isn't really enlarged and you're safer doing just the ascending aorta.
Yeah,
and that's my simple rule of what it looks like at the time.
That's exactly the approach that we take.
Just anecdote, because I've also seen my registrar has walked in, but he'll tell you that we had exactly this on Tuesday, and the decision was only made when I decided just to replace the ascending aorta, but there was calcification at the sinus-tubular junction, and I thought there'd be more trouble from just getting that hemostatic than doing a root, so we did a root. And it really is as individualized as that when you see what's in front of you.
And Tim Graham.
Let me just go back to the real world, which was the question earlier about the patients who have aortic valve replacement, but they've got a dilatation and it's in the order of 45 to 50. I just wondered what people felt was the age influence on the decision about whether you replace the ascending aorta. There's quite a lot of difference between a 65-year-old and a 79-year-old when they're faced with these patients. So I'm disappointed with the guidelines. There's no reference to that, is there, within the guidelines?
I think physiological age is a much greater predictor, is a much greater factor than chronological age.
And how do you measure that? Just remind me.
The end of the bed test.
Can I make a comment on Tim's point? This is really difficult area when you're operating. I feel that sometimes if the dilatation is limited to the ascending aorta and you have a circular formation that you can put a clamp and do the operation as moderate hypothermia, you just go ahead and replace the root. If the dilatation is going all the way to the arch and you know that you need hypothermic arrest, I tend to just leave it alone. And I know this is possibly illogic because it probably reflects that there is aortopathy with this generalized dilatation, but this is what I do myself. I think if I know that it's going to be deep hypothermic arrest, I just avoid replacing the root. I don't know what you think about that. If you put a clamp and do it at 30 degrees, it's completely different operation.
Yeah.
I'd agree with that, but to also answer Tim's question, I think that you got to think about what it is you're trying to prevent, and if it's an acute aortic event, dissection, then you can take refuge in Laplace's law and just say, if I reduce diameter, I'm going to massively reduce the wall tension, and that will do for the 75-year-old plus. 65-year-old, 60-year-old, different story.
And I've got one question before we finish, because we need to get on to Andy's talk. And that's about, we heard this earlier from Rachel about indexing of diameters and things when we were talking about the aortic valve. And yet for the dimensions quoted for the ascending aorta, we're still at static, non-indexed dimensions. And just looking around the people in this room, that the range of aortic size is going to be huge. I know the Cleveland Clinic, they have a sort of, Svensson's got a formula.
Svensson's got a formula, a pi r square formula based on the ratio of the size of the
area, the maximum sort of cross-sectional area and the body area of the patient. And if it's more than 10, I think one is in centimetres squared, one in metres squared, and if it's more than 10, they use that. And I think in Britain we're bad, the adult surgeons, at thinking about indexing. But again, the guidelines have come out with fixed 55 millimetres. Yes, 54 millimetres, no, 56 millimetres,
the American guidelines specifically say not to index.
Yeah.
They specifically state don't index. Yeah. We use indexing. We don't use Svensson's, but we use the CODI data on the nomogram of risk of rupture, dissection, death. So we use that within our aortic practice to risk stratify and counsel patients as to what we feel their risks are. So we will index.
Mm. But it's a difference of opinion, because for the valve you're saying indexing is important, but then for the ascending aorta they're saying indexing isn't so important.
Yeah, I think the index is important for the ascending aorta.
Yeah. Okay, thank you very much.